Hello, RD2B, and welcome to the Diet NPO podcast. My name is Zach Caseberg. I'll be your host, your moderator, your tutor, and what's up with all you brilliant students? I hope you're all having a really nice week, whether you're working, you're studying for the RD exam, traveling, or just hanging out in general. Being in university food service like I am means that July and August really picks up around this time. That's usually due to training, to short staffing, starting out the semester, and I'll admit, generally it sucks, but you have to do the job, right? This is why we get these whole 2 weeks off of paid time off during the holiday to kind of balance that out. So I don't have too much beef with that. What I do have beef with is at times I miss being a clinical dietitian. Not even gonna lie to you. It was my last gig and really my first gig when I got out of college was being a clinical and being an oncology dietitian. And it was just amazing to get thrown into so many situations related to clinical, community, social aspects of dietetics. It is by far the best way to do the job. And one of my favorite skills, and the dark part of me really misses, is malnutrition and diagnosis. Malnutrition was such a constant in the job. Everyone who walked in, because a lot of times if someone's coming to the hospital, generally it's because they are the sickest of people that end up coming in, and malnutrition tends to follow them because they might have not have been taking too well of care of themselves or maybe having some severe issues. So you're just getting a lot more exposure to malnutrition once you're working in the clinical setting. You also develop a bit of a shell because when I'm going through an assessment of someone for malnutrition, especially a nutrition-focused physical exam, I cannot be reactionary when I see that their clavicle is protruding so much, or I can't be reactionary when they tell me they've only been eating half of a meal every day for the past 3 months or so. Maybe share a case or think of a case from your internship where you saw a really good case of malnutrition, and that'll help you out when you get onto the exam. I always like to think of my little old ladies, right? I call them my LOLs. So my LOLs, a lot of them, they'll have this clavicle that is just protruding so much. I always say it looks like it's a handle of a bicycle. Like it looks like it's protruding that much that I could grab it and wrap my hands around it if I had to. So that's kind of my story about how you can't be reactionary when you're talking about malnutrition. So why not make sure that you and I are up to speed on malnutrition, the medical nutrition therapy, and talk about how we even find and diagnose that patient with malnutrition in the first place. If you work at a large hospital with thousands of patients, how are you as an RD going to be able to know which patient has malnutrition in the first place? You gonna walk in every door and knock in and say, hey, are you malnourished? Well, of course not. From my experiences, I've had a lot of great nurses that were there to assist with the screening process of someone who is admitted and seeing if they have malnutrition. You might have different criteria, such as a patient's weight or height that may trigger you to see them, labs, or you may even run a patient through a malnutrition screening depending on what those hospital procedures are. There's a handful of tools that the Academy recommends for diagnosing someone with malnutrition, or screening them, I should say. We're going to hit a few of them briefly, one by one, and just give you some short details about them. MST, the Malnutrition Screening Tool, is one of the most common and most recommended type of screening tools for malnutrition out there. It is as easy as it gets. It asks a few simple questions, which I don't think you'll need to know all of these, but I want you to be nice and familiar with what the tool assesses. By the way, the MST is great and it's recommended for any adult that is admitted to the hospital. So adults admitted to the hospital, it's a good way to be used for all of that. When you go through these, you can say like yes, unsure, or ranking through here. So the first question, have you recently lost weight? No, unsure, or yes. Yes would prompt them to ask, how much weight have you lost? Is it 2 to 13 pounds? Is it 11, kind of showing that difference there. You'll get different scores based on how much weight you have lost. Have you been eating poorly due to low appetite? Yes or no. These questions of the MST are going to total up with a score that would trigger a screening. and that would normally notify us, the dietitian, to go see that patient. You can also use a similar one, and many of these are very similar. That's why I don't want you to learn them all. The MUST, the Malnutrition Universal Screening Tool, is for adults who are malnourished, at risk for malnutrition, or obese. And it scores them based on a few differences, such as BMI, percent weight loss, disease effect, and scores them based on those to total up to kind of hit that diagnosis of malnutrition. The mini nutrition tool assessment, short form, is what is specifically used for those mini grandmas out there, or those people who are ages 65 years or up, or who are at risk for malnutrition. This can be extensive, but I'm glad it's the short form because it's asking things such as declining food intake, weight loss, mobility, psychological stress, presence of dementia, BMI, and even takes that physical kind of measurements of some circumference areas. These scores are going to total up for a normal, at risk, or having malnutrition. Now, I want to just kind of mention here that we're not exactly diagnosing them, right? We're screening them for malnutrition. So if they test positive on the screening, it means they very likely may have malnutrition, but they haven't been diagnosed yet. I'll also mention the NRS 2002, the Nutrition Risk Screening. This can be used for hospitalized patients who are adults, and it checks for low BMI, recent weight loss, reduced oral intake, and the presence of severe illness. I reviewed the position paper from the Academy from 2020, and the subjective global assessment was not mentioned in there, but I think I'll discuss it just to make sure I cover my bases. Subjective global assessment is an effective assessment looking at patient history with intake, weight loss, GI ability, functionality, even goes as far as to look at some nutrition-focused physical examination results, which I think really makes the SGA one that might be more appropriate to be done by a dietitian or a nutrition professional who's able to properly diagnose someone in that way. The Academy, Aspen, and ESPEN have come to a point to try to standardize the diagnosis of malnutrition because it seems like it's all over the place. You see, by using these screening tools, as I mentioned, we've triggered their level of risk. We know if they're at risk or of having malnutrition. But we know that diagnosing malnutrition, it takes a little bit more of that from what you've picked up in your internships. So malnutrition has such a high effect on patient length of stay, hospital cost, morbidity, and mortality, that's why hospitals become so focused on malnutrition and preventing and treating it properly. So it's our responsibility to know how to diagnose it, to help with proper insurance use, and to get the patient taken care of here. Malnutrition is generally caused by three etiologies, which you've been familiar with. We have acute illness malnutrition, chronic illness malnutrition, and social environmental malnutrition. I want you to imagine that malnutrition chart that you had in your internship, that you saw those three columns. Each column had a context of acute, chronic, or social environmental, and then there were two levels broken up from moderate or severe. So someone could have acute caused malnutrition, but they could have moderate malnutrition or severe within that, right? And I'm going to discuss malnutrition in the context of chronic illness to remind you, but I recommend that you check out on your own, looking for those social environmental circumstances, as well as the acute illness malnutrition, just to make sure that you're nice and familiar. Chronic malnutrition, remember, we're thinking long-term type of health effects, such as HIV and AIDS, cancer, or even renal disease that we've had for a long time that's affecting our intake or our ability to, really absorb nutrients in any way. Malnutrition in the chronic illness context, again, we're going to have our moderate versus severe effects. So we're going to go one by one to talk through these. Starting with energy intake, we need two or more of these criteria, don't we? If someone has moderate malnutrition, they would be having less than 75% of their estimated EER for greater than or equal to 1 month. If it was severe, it would be less than or equal to 75% of estimated energy requirements for greater than or equal to 1 month. Then we can interpret things such as their weight loss. So talk it back with me. If it was 1 week for non-severe, then they would have 5% weight loss for chronic. If it was 3 months, it's 7.5%, 6 months, 10% weight loss, or 1 year, 20% weight loss for those. That is all in the non-severe. If it was the severe, it would just be greater than that. So again, it would be in 1 month, greater than 5% weight loss. In 3 months, greater than 7.5% weight loss. In 6 months, greater than 10%. And then in a year, greater than 20% weight loss. So that's just for the weight loss breakdown. Then we get into some of those kind of nutrition-focused physical examination results to tell us what type. So if they, for instance, had mild loss of body fat and mild loss of body fat and muscle mass, then you would know the patient has physical findings that are falling more into the non-severe or the moderate category of malnutrition. But if they had severe body fat and severe muscle mass loss, because you saw great loss of those amounts of kind of fat and muscle mass, then you'd be saying, okay, they're more towards the severe side of it then. We can even look at things such as fluid accumulation, hand grip strength, to be other ways that we can diagnose malnutrition in that way. So now you've become nice and familiar again with the chronic side, and on your own, it's just time to check out a little bit of that social, environmental, as well as the acute phases. Check those out from your previous resources, or hop into the academy and take a look what Aspen and Espen has to present. When someone has malnutrition and you've gone through that diagnosis criteria, you need to determine the cause of the malnutrition. And you're trying to determine, is this a cause of the patient not getting enough protein in their diet, or is it caused by them not getting enough protein and calories, for instance? So we're going to go through 2 different terms of adult malnutrition that you need to be familiar with. One is marasmus. Individuals with marasmus have protruding ribs, obvious signs of fat loss, muscle loss through their appendages, and they're generally pretty thin and skeletal looking because they have a lack of calories and a lack of protein, both with marasmus. So you're seeing a very skinny individual, not much body fat on them, not much muscle mass on them, pretty protruding ribs, and a very thin stomach is what you're seeing. Your alternate one to be familiar with is kwashiorkor, the Ghanaian word for disease that develops when a child is weaned off of the protein-rich breast milk. Kwashiorkor is caused by protein-related malnutrition, not calories. Picture that African child who has that large, bloated stomach. Now, they get this large, bloated stomach because of the lack of protein and the lack of albumin. The liver, because it has such a low amount of protein in it when it's lacking albumin, it actually begins to swell up with stored fat because there's no hepatic proteins to help balance things out. So we know they'll have that appearance of a very swollen belly, but that won't be your only way to develop the state of malnutrition for these patients. You can also use your nutrition-focused physical exam to help you out as well. Why don't we go through these together, head to toe, to talk through the major compartments of muscle and fat in the body. Starting with the temporalis muscle. If you're listening in to me, make sure just raise your hands up, put them right along your temples, and feel that temporalis muscle. So the temporalis is going to be a muscle area, meaning if a patient has a depression in that area, then they have lost muscle or they're not eating enough protein. Slide down to where your eyeballs are because you're going around your orbital area. The orbital area is where we're going to see more fat-related issues, okay? So if you kind of palpate right underneath your eyeballs, you'll feel those pads, those orbital fat pads, and when someone is malnourished, those are going to become very sunken and very depressed, right? Next, if you go down to your cheeks, we know that when we lose weight, you can see it in the cheeks a lot, right? The buccal region where your cheeks are going to show where fat stores are. So when someone doesn't get enough calories in their diet, generally, they'll get a sunken look in their cheeks. Slide down to where your shoulders are into your clavicle. Feel above and below. Here's my little old ladies with the protruding clavicle. So that clavicle that clavicle bone is surrounded by muscle, right? It's got that pectoralis muscle directly underneath it. And as I lose more muscle in my chest area, that clavicle begins to protrude more. So you know that the clavicle is going to be an area of muscle loss and not fat loss, right? Slide out to the outside of your shoulder, right near your deltoid and your acromion. The acromion process is that little bony part that sticks up out of your shoulder. Normally when that's sticking out a lot, that can be due to lack of muscle. As well as the deltoid. The deltoid's on your outside of your shoulder. You notice that when that deltoid becomes very squared off, like there's no muscle surrounding it, that is due to muscle loss, malnutrition. Now you don't need to scratch your back, but check someone else's, because you have your scapula or your subscapularis, and there's this whole region of bony protrusions that if you don't have enough muscle surrounding them, they will be protruding significantly. So the scapular kind of region is all going to be focused on muscle loss. Feel your ribs, feel your hip bone. You're going to be looking at your ribs and your iliac crest, which is that whole area along the midline. And that's going to be due to fat loss. So as someone loses and doesn't consume enough calories, they're going to lose body fat in this region. And then the top of their ribs are protruding. The top of their hip is generally protruding. And that's what you're seeing with fat loss for this patient. Make an OK sign with your finger, and remember that little interosseous muscle, right? That's right between your thumb and your index finger. The interosseous is a muscle loss area where when someone loses a lot of muscle, they'll have a large depression in that interosseous area. So we know that's muscle loss. Going down into the legs, you can always observe their quadriceps muscle to see if that's wasted around. You can look at their patellar region to see if there is a noticeable lack of muscle surrounding that patellar region, as well as you can go to the calves in the gastrocnemius muscle to really see if they have significant muscle loss there. And I can't believe that I forgot one area. Stick that arm up, grab the back of your arm, pinch and pull down. This is that triceps area that you're assessing. And I just want to mention here that although the tricep is a muscle, what you are assessing when you do that pinch and pull in the triceps area is not muscle. You are assessing their level of body fat because that is a storage area for fat on the body in that triceps region. Okay, so need to be nice and familiar with that. How you treat a patient with malnutrition will be mostly dependent about what you've learned during that physical examination, your nutrition diagnosis, and other assessment-related information, such as the diet history, just to give you one example. I'm going to discuss 2 case studies to help emphasize our steps of malnutrition here. So let's say we have our first patient, Ray. Now, Ray is undergoing chemoradiation for oral cancer. They have oral and esophageal cancer. Ray refused to have a feeding tube put in and has gone some period of time now without eating, and this was during treatment, so pretty scary. Ray is suspected for malnutrition, but you need to diagnose. You completed your diet recall, physical exam, you reviewed his chart, and you suspect that Ray has protein-calorie malnutrition. He showed this based on meeting well under 75% of his EER, and he showed some physical signs of loss of muscle and fat in his body. He's a pretty skinny guy. So what's the primary focus going to be for this patient when you're thinking about it, right? Well, protein of calories, of course, because we found that Ray likely has marasmus, he's missing protein and calories. A good course of action would be educating the patient on protein and calorie foods, But the overall goal is you've got to get more calories and protein in this guy. You have lots of options to do so. Maybe you decide we're going to go the whole foods route. We're going to get Ray to do peanut butter, a scoop of peanut butter as a snack twice per day to increase his protein and calories. Maybe Ray is interested in doing an Ensure or a Boost supplement that has calories and protein in it, not just a bunch of protein. No low calorie shakes here. Or you decide that Ray finally just needs to get the feeding tube, and you know that you would be providing a nutrition prescription that gets him both high protein and high calories for that tube feeding, right? Now let's discuss Mary. Mary is this elderly little old lady, no teeth, and she relies on a lot of processed food items that she microwaves. Upon discussion and physical exam, you realize that Mary has really normal amounts of body fat, but she has heavily depressed temporalis, protruding clavicles, squared off deltoids, and an obvious loss of muscle in her interosseous. So now Mary is going to need to get some more protein in this case. She probably has plenty of calories. She appears to have plenty of body fat on her body. But from the diet recall and from the nutrition focus physical exam, it seems like we need to get more protein in her diet, which is what we're going to do. Whether that's educating her, maybe we're going to do a high protein supplement like Ensure High Protein, or maybe we're going to add high protein foods as a snack to make her kind of get more protein in her diet, or teach her how to make her own whey shakes. Whatever it is, we don't want to treat this patient with too much calories, as this is not the goal. We want to focus on getting the amount of protein they need to hold on to as much muscle as they can for those malnourished patients. Today on the What's Eating You segment, I just wanted to talk through a good one this week where I had my parents over, so I wanted to make sure I threw something together. It's grilling season, so despite all the carcinogens, I wanted to try it out a little bit and get my use out of it. And we had some nice local cheddar brats from a local butcher. And since I was having them over, I wanted to do kebabs. So I did kebabs with a diced piece of brat, bell pepper, red onion, and mushrooms. And we also had this kind of it's like a European kebab seasoning that I could throw on, that none of it's in English, so I don't really know what's in it, to be honest with you, but I'm guessing it's a mix of herbs, of garlic powder, of paprika, and different seasonings to help with a kebab seasoning. So we added that on there, kind of mix it with some oil as well. And I always struggle with kebabs because it's like, do I put extra meat on this one? Do I put extra veggies on this one? But then I just decided hey, it doesn't matter. It all looks beautiful once it ends up on that kebab skewer. So throw it all on there and have some fun with it. The only thing I struggle with is I want to ask, are you like me? Are you an animal who just eats your kebabs directly off the stick? Or are you like my parents who decide to kind of strip the kebab completely before they decide to eat it? I'm not sure. But thanks for listening and watching the pod this week. Don't forget to help in any way you can just by, reviewing, subscribing, all those things that everyone tells you to do with their podcasts. Check me out on Instagram, Threads, watch this on YouTube if you'd like to for Zach_snacks, anywhere you want to. Feel free to DM me if you want to talk about advice for the RD exam or just about setting up some tutoring possibly. Have a great week and happy studying to all of my favorite RDs to be.